Yes, I'm David Suderline. I represent the Roanoke and River Valleys in the Senate here.
I'm Tara Durant, representing 27th Senate District, which is most of the county of Stafford, city of Fredericksburg, and portions of Spotsylvania County.
My contained entirely within Arlington County. And our staff, do you want Julie?
I'm Julia Bergamini with the Division of Legislative Services.
Hannah Yates with the Division of Legislative Services.
Chandler Brooks, same here.
Andrew Horton, Committee Operations.
Okay. Eric,
Eric Bingham with Senate Committee Operations.
Okay. Well, with all this help, we should be able to move smoothly. I know there are a lot of people here, and I'm expecting that most of you are here regarding Senate Bill 280. Is that correct? I am going to call the Chair of Education and Health, Senator Hashmi, to present first, so maybe we can make others comfortable. Okay. Senator, before you start, I just want the clerk to know we did introduce ourselves, so I would like it noted that we have a quorum, if that's your conclusion. Okay, we have a quorum. Okay, let the record note. Senator Hashmi, would you like to present 280?
Thank you, Madam Chair. Yes, SB 280 is also known as Medical Aid in Dying, and this is the third session that I am introducing this bill, reintroducing it again. Our focus on this legislation is really to provide an avenue for individuals who are facing terminal illness, an option that's compassionate, an option that allows them to make a decision for their end-of-life processes. This legislation allows an eligible individual the autonomy to decide when suffering becomes too great and to alleviate that suffering on their own terms by dying peacefully in their sleep, should they choose. This is an option that is open to a very limited category of individuals. It is an option available only to adults who are mentally competent, only to adults who are able to self-administer the medication, and only to adults who have 6 months or less to live as determined by their medical team. This bill works in conjunction with hospice and palliative care, and we know that in those circumstances, a large number of patients suffer as they face end-of-life issues. And not only are the patients suffering, but their family members are suffering. Madam Chair, I continue to bring this bill not because it directly impacts me. I have not had the experience myself of working with a family member who or a loved one who wanted to make this decision and suffered as a result of not being able to have control over their end of life. I bring this legislation repeatedly because so many families in Virginia have reached out. So many families within my own district have shared stories of the excruciating crisis that they and their loved ones face. And so I bring it on behalf of many, many Virginians. 11 states have already passed legislation similar to this. Washington, D.C. has passed similar legislation, and so many constituents have shared that their choices as they face end of life is to actually move to another state that would allow them to make this final choice. It's not easy. One person in particular that I remember quite vividly shared that he was born in Virginia, raised in Virginia, has lived within a 25-mile radius of the same location, and he wants to die in Virginia, and he wants to die on his own terms. But should the situation become such in his personal life, he's ready to relocate to another state, and he would prefer not to do that. He would like to pass peacefully in his own home, surrounded by his loved ones, and not have to go to another state. And it's not simply a matter of traveling to another state. Most states, like Virginia would have a residency requirement, that individual would actually have to be a resident in Virginia in order to make these kinds of accommodations. And so there are a lot of safety rails put into place around this particular legislation. Madam Chair, we know, most of us know and love dearly Congresswoman Jennifer Wexton. She too is facing an extremely excruciating decision in her personal life, and she wanted to be here today to share her support. But she is not able to travel and join us today, but she has instead sent a statement. With your permission, I would ask Senator Boysko to read Congresswoman Wexton's statement into the record.
Yes. Senator Boysko, would you like to come forward and read that statement into the record?
Yes, ma'am. Madam Chairman, Chairwoman Hashmi, members of the committee, former colleagues and friends. During the 2018 Virginia legislative session, while I was serving in the state Senate, I met with a group of constituents who wanted to discuss death with dignity legislation. I could never have imagined back then that just 5 years after that meeting, this issue would become so much more personal for me. As many of you know, last year I was diagnosed with progressive supranuclear palsy, known as PSP, a neurodegenerative disease which I have described as Parkinson's on steroids. It is an incurable and extremely aggressive disease that is resistant to treatments usually effective in Parkinson's cases. PSP robs people of their ability to walk and speak before inevitably taking their lives within just a few years. It has caused my physical condition to deteriorate rapidly. I started 2023 striding confidently around Congress, covering several miles a day as I walked between my office and committee hearings and floor votes. By summertime, I was walking more haltingly and depending on my sturdy walking poles to help me maintain my balance. And now, I use a walker and gratefully accept rides across Independence Avenue to the Capitol when votes are called. In all likelihood, I will be confined to a wheelchair before this year ends. There is no getting better with PSP. Treatments and therapies may help ease the severity of my symptoms, but the progression is quick and the prognosis is bleak. PSP will rob me and thousands of other Americans of our ability to walk, talk, or even to feed ourselves. We will require extensive and expensive institutional or in-home care. As hard as it is for those of us with this disease, the emotional brunt is perhaps even more so borne by our loved ones. My husband Andrew and I were supposed to be getting to the good part of midlife as new empty nesters. Instead, he will be a caregiver, and we are looking at costly renovations to enable me to remain in our home when I can no longer walk. We will not enjoy a leisurely retirement a decade plus from now. There will be no scuba diving and Scrabble on the beach. Instead, there will be suffering and then mourning. I know it has been incredibly hard for my college-age sons to watch their vivacious, cool, for a mom, confident Congresswoman mother go through these changes and challenges as well. And it will only get worse for them, and I grieve for the painful journey I know they will take. My family was never expecting to happen this, having happened this to us, but it could happen to anyone. Unfortunately, we are not alone. There are thousands of Virginians dealing with terminal diseases, facing unthinkable challenges and choices because of these devastating health conditions, and that is why this legislation is so incredibly critical. It is a vital step towards allowing Virginians to gain the dignity and freedom and peace of mind that we deserve in the face of a tragic terminal illness like mine, prohibiting willing physicians and their terminally ill patients and our families from working together to create an end-of-life plan that is peaceful, humane, and allows us to maintain our dignity is needlessly cruel. It is heartbreaking to watch a loved one struggle through the pain and suffering and trauma that comes with a terminal disease, and individuals and families across Virginia should be able to make these decisions that is best for each of us in such difficult circumstances. This Death with Dignity bill, Senate Bill 280, puts forward today something that will do just that. It is a tried and tested process, both legally and medically, that has given those suffering from terminal illnesses and their families facing unthinkable challenges in other states the freedom to choose the best path forward for them. I want to thank Senator Hashmi for leading this bill on behalf of families like mine across the Commonwealth. As my PSP has worsened, it has become clear that no matter how many medications I take or how many hours of physical, occupational, and speech therapy that I do, I cannot stop PSP's inevitable progression. It has robbed me, my family, and the many people in my life who I love and who love me of so much. But if this bill becomes law in Virginia, it will return the control over when, where, and how our stories end to us, not to our diseases. And that is the greatest gift you, our elected officials, can give us. Thank you. That is from Congresswoman Jennifer Wexton. Appreciate it.
Thank you for presenting that. I did serve with Senator Wexton, and she was an amazing person. She's still an amazing person, and she's facing this challenge with grace. Grace and grit. She's a fighter, and I believe that the issue she's going to fight for will continue. The fight will continue. I sense that there are a lot of people that will have strong views on this one way or the other. I am going to ask that we have 10 minutes of comment in favor of this bill and no more than 10 minutes in opposition, and then the discussion will be with the subcommittee. So I don't know who has, I don't have a list of people who have signed up. That's not what we do in the subcommittee, staff are telling me. So if you can sort of organize yourself and come forward. Again, I'm going to allow 10 minutes of comments for those who are in favor of this bill or would like to offer another guardrail to the bill. You're in favor of the concept and would like to offer a guardrail. Okay, please come forward. Welcome.
Members of the committee, thank you for having us here today. My name is Melissa Stacy. I'm the Northeast Regional Campaign Manager for Compassion and Choices and Compassion and Choices Action Network. We're a national nonprofit focused on forwarding end-of-life options for everyone. We are here today in support, and I have submitted written testimony to the committee and subcommittee. And so with that in mind, instead of providing my testimony, I'm going to read the testimony of a woman named Barbara Green of Church Falls. She is unable to be here today because she is actively dying, but wanted her story to be heard. So this is Barbara's story. In July of 2022, My world was turned upside down when I was diagnosed with metastatic pancreatic cancer. My doctors told me that the average pancreatic cancer patient lives 8 to 11 months after diagnosis, although many die sooner than that. Only 1% of people with my disease are alive 3 years after the cancer is found, and almost none are cured. As a Virginia resident who has been working for years on legislation for medical aid in dying, I suddenly realized that my own life-threatening diagnosis meant I needed to move to D.C. I found it absurd that the choices of Virginia lawmakers made it impossible for me to continue to live in Virginia, where I've spent most of my adult life, and that in addition to dealing with a cancer diagnosis, I also had to start dealing with moving. Knowing that aid in dying would be available to me once I moved to DC gave me some sense of control over a very uncontrollable illness that has no cure. As I worked to structure my move, finding both a suitable rental and a cooperative doctor, I suddenly realized that months had passed and I'd surpassed the time frame when I was told I would die. This complicates my decision-making because I want to stay in my home state. Since I have no idea when that will happen, it's become a constant concern that I don't wait too long and then become stuck in a state that will not honor my wishes. Please don't deny this end-of-life option to Virginia residents. It's legal to poison me with chemotherapy drugs that eventually my body will be unable to handle, but illegal in this Commonwealth to let me die on my own terms rather than waiting through months of physical and emotional suffering. I should not have to leave Virginia to achieve bodily autonomy. Thank you.
Thank you.
Hello, members of the committee. My name is Shannon Hibbard, and I am reading on behalf of Alice Alvord, who could not be here today. My name is Alice Alvord from Virginia Beach. I support this bill and only wish it had been available earlier. My 75-year-old husband ended his life by suicide 2 years ago after valiantly fighting cancer for years previously. Had Virginia already passed such a law that is before you now, there is no doubt in my mind that he would have preferred this gentler option. Being together with his family when he took his last breath would surely have been a comfort to him, and without a doubt, also a comfort to his family. I would not wish the trauma our family endured by his dying a violent death alone on any other family in Virginia. There is a more compassionate choice for those individuals like my husband and for their families. I beseech you to grant them your compassion. Thank you for your understanding. Respectfully, Alice A. Alvord. Thank you.
Thank you.
Hello,
Welcome.
my name is Joseph. I live in Hanover. Last May, my grandmother was given 8 weeks to live due to aggressive cancer. Living in Canada, she had access to medical assistance in dying. Having this option gave her immediate comfort. She was not scared to die, but she was scared of suffering. 6 weeks later, her symptoms had become intolerable, so she arranged for her death, choosing to have it at home. She spent her last day surrounded by loved ones, completely lucid, able to savor every last moment with us, as we did with her. Her death was profound and beautiful, a moment which touched all of us, brought us closer to each other, and helped us better understand the mysteries of living and dying. Without medical aid in dying, my grandmother would have been fearful throughout her final months, and as her illness became insufferable, even when she knew she was ready to go, I would have helplessly watched her suffer, or else given her medication that took her pain away, yet made her no longer herself. This would have been a tragedy far worse than death. I am so grateful that medical aid in dying was an option for her, and I humbly request that it be made an option for all of us here in Virginia.
Thank you, Joseph.
Hello, my name's James Beasley. I live in Northern Virginia. I wish to inform members of this committee that I and a majority of other Virginians support the right for terminally ill individuals to have the option to end their lives if and when their suffering becomes unbearable. This bill provides that choice with over a dozen safeguards included to ensure that coercion does not occur and that anyone who makes the decision to end their life can do so only if they are deemed mentally capable. The history of similar legislation in other states indicates that there have been no substantiated cases in which these laws have been misused. If enacted, this law would allow anyone to change their mind at any time. Indeed, in many prior cases, persons who have asked for and received the drug that they are considering using have ultimately chosen not to use it. I want to live in a state that cherishes life but also provides freedom of choice for me and anyone else who may someday face the prospect of enduring needless pain and suffering when all hope for survival has been lost. Thank you.
Thank you, James.
Yes. Dear committee members, my name is Wayne Swatlusky, and I live in Richmond. I'm an ordained Catholic priest and served in clerical ministry for 15 years before resigning. I am now a minister with the Universal Life Church and a hospice visiting volunteer. In these positions, I have been with people during their dying hours. For some, they have been marked by extreme physical and emotional suffering, a very unnecessary and inhumane vital passage, which could have been avoided if medical aid in dying had been an option. I am not afraid of death, but I am afraid of dying. So please vote yes on this bill. And thank you for your time.
Welcome.
Hi. I'm Dr. Patrick Newstadter. I'm a primary care physician who's practiced in Virginia since 1986. First in private practice and now as the medical director of the Moss Free Clinic there. And I treated a lot of people who are terminal, and I believe there's a lot of unnecessary suffering among the terminally ill patients because of lack of access to medical aid in dying. It's a small number of people who are appropriate for or would choose to foreshorten their dying process with the aid of medicines prescribed by their doctor, but I see this as the ultimate in patient autonomy and self-determination, and it is they that should be the ones who are making this decision and not have greater suffering forced upon them by the philosophical and religious beliefs of politicians and conservative medical organizations. The objection from some doctors that they are healers and not in the business of ending lives overlooks that these people are not healable. They are dying anyway. I see my duty as a doctor to minimize suffering. The evidence from states where medical aid in dying is already legal shows that the safeguards are effective in stopping people from being coerced into ending their lives or doing so capriciously. I urge you to support and legalize medical aid in dying in Virginia.
Thank you, Doug.
Madam Chairman and members, thank you for giving me the opportunity to testify. I am a retired cardiologist with exactly 60 years experience as a physician. In my career, I've witnessed several patients who were dying a prolonged death in agony and desired to end their pain and suffering. I've also experienced that in my own brother, who begged his son to let him go when he was faced with multiple organ failure and mutilating surgery. I think the best option for these people is to let them have control over their life, remaining life. The husband of one such patient called it incredibly cruel that his wife was denied the option. I strongly support SB 280. Thank you.
Thank you. How many more speakers are lined up for this? Because I will extend the speaking. Okay. Why don't we extend the speaking allotment by 5 minutes, please, on the pro side, and the opposition would get the same.
Thank you.
Welcome.
I'm the Reverend Dr. Fred A. Salto Jr. I'm a retired clergy person who served the church for 45 years. I live here in Richmond, Virginia. During the course of my ministry, I witnessed firsthand the passing of numerous people who would have welcomed the discussion of choice if medical aid in dying had been an option. Medical aid in dying was presented in this bill is an option. It is not a requirement. It is an option in the same manner as that of radiation, chemotherapy, stem cell replacement, and other medical procedures that can be offered to patients with terminal diagnosis. Patients have choices to make during their care when they are faced with end-of-life decisions. Medical aid in dying should be one of those choices that is offered to a terminal patient with the input and the approval of his or her medical team. Thank you.
Thank you, Doctor. Welcome.
Thank you. Chairwoman and members, my name is Christine Woods. I'm from Hampton, Virginia. And I'm here to discuss that certainly there is strong opposition by some whose personal or religious beliefs preclude them from considering this option. And I respect that. Yet it's important to note that they need not choose it for themselves. They need only to find tolerance to permit other terminally ill people to make their own life and death choices. My ask is that you summon up the compassion or your own respectful tolerance to support 70% of your constituents, as well as those Virginians suffering in the dying process. Please support this bill. Thank you.
Thank you, Christine.
Thank you for allowing me this statement. My name is Stephanie Stringer, and I live in Norfolk. When my 92-year-old father died, he had terminal multiple myeloma and kidney failure. As a Virginia resident, his only option to avoid physical pain and suffering was to voluntarily stop eating and drinking. Because he was otherwise healthy, it took him almost 25 days to die, instead of the roughly hours it would have taken with medical aid in dying if that had been available to him. For more than 3 weeks, my mother, my sisters, and I watched him wither away until he took his last breath. This should never be the only option to avoid a painful death. There are 10 states plus Washington, D.C. that allow this, and I'm asking you to vote yes on SB 280. Thank you.
Thank you, Chair Fabiola and members of the committee. My name is Sarah Elkins. I work as the Senior Campaign Organizer for Compassion and Choices, and I'm here today to read testimony in support of S280 on behalf of Mike Perlman of Chantilly, Virginia. I speak to you from a personal standpoint. Our daughter died in 2013 suffering from an autoimmune disease with neither a cure nor effective treatment. She was 38 years old. Near the end of her life, Sandy was in terrible pain. On her birthday, Sandy made the decision to enter hospice care. Even getting out of bed had become almost impossible. Her lungs and liver were failing. With the support of hospice care, Sandy's pain apparently subsided. I say apparently because Sandy was now in a coma. She died there shortly thereafter, 2 weeks after entering hospice. I can't say with certainty that Sandy would have chosen medical aid in dying if it was an available option. She would have strongly wanted the opportunity to make her own decisions. She had made her own decisions throughout her adult life, and including her decision to enter hospice care. Endings matter both for the dying person and for those left behind. I urge your support for the passage of Senate Bill 280. Thank you. And there's one more. Thank you.
This is our last speaker.
Thank you for giving me the opportunity to speak today. My name is Judy Welp. I'm from Norfolk, Virginia, and I'm also one of the organizers for Compassion and Choices here in Virginia. Once death is inevitable, modern medicine can keep people alive a long time. If this is their choice, they deserve every intervention possible. However, in the work I do, I frequently hear people express that they are at peace with the fact that they are dying, but that they are terrified of the suffering that they and their family will have to go through in the final days and weeks of their lives. They want to die while they're still themselves, not being a burden to their families, not using precious, dwindling resources, and not as some diminished shell of themselves. No one will ever be forced to use this option, but it will be a great comfort to those who wish to. For the people of Virginia who want self-control over their end of life, please pass Senate Bill 280, Medical Aid in Dying. Thank you.
Thank you, Judy. So that was 15 minutes. Speakers, your presentations were very well put together, and thank you for putting so much thought into your remarks. Now, I believe there may be folks who wish to speak in opposition to the bill. You too will have up to 15 minutes. Welcome.
Thank you for allowing me to speak in front of you today.
Sure.
My name is Nicole Davis. I live in Virginia Beach. I'm from the Norfolk area, and I speak in regards of the Secretary for the Virginia Associations for Centers for Independent Living, or VASIL. In theory, this sounds like a bill that allows for choices, and that allows people the right to not suffer or be in pain. So how could that be a bad thing? Nobody wants people to suffer. But when you look at states where physician-assisted suicide is an option, and you look at a report from a state like Oregon that has passed it, the three most frequently reported reasons for using physician-assisted suicide were: one, a decreasing ability to participate in activities that made life enjoyable; loss of autonomy; and loss of dignity. Those are not focused on pain, but around barriers that impact people with disabilities. Barriers that I, as a person with epilepsy, have dealt with. When you truly look at the data and why people have chosen this, think about it. We are stating that when a person's disability condition becomes more significant and their life changes, we're now saying death is an option. If you lose the ability to provide your own care and you rely on caregivers that may or may not be family, that is hard. And having to navigate that is not easy. But when it becomes hard and overwhelming, and having to ask your loved ones sometimes to get you out of bed or to dress you when you're not aware of resources that could be there, when faced with those situations and emotions, we're now placing death on the table. People with disabilities face barriers. I myself have had to encounter a life that is constantly changing due to the fact that I have seizures. And it's hard. And what my coworkers and peers in the disability community fear is that when hard conversations have to occur, is death what is selected to resolve this? The data shows that the reasons why this choice is used in other states is not primarily physical pain, but people are choosing death because of the barriers that are related to them having a disability. And let's be clear, when we talk about illnesses and conditions, we are talking about living with a disability. I will end by saying this. Most of us, and I've heard it a ton in my life, have heard someone say, "I could never live like that." Do they say that because they do not believe it is dignified to live a life with a disability? Or do they believe that they would not be supported by others? Lack of knowledge about how people with disabilities navigate life is huge. And it is due to this lack of real-world knowledge that we get movies such as $1 Million Baby or Me Before You that focus on how death over the possibility of a life with unknown experiences is better. Assisted suicide will diminish already scarce supports, increase the potential for coercion, and ends of the lives of people simply because they have a disability. Our focus must remain on improving, not ending, the life of people with disabilities. Thank you.
Thank you, Nicole.
Good afternoon. My name is Eileen Roberts. I had a group called Parents for Life, but today I'm wearing a different hat. As my husband of 49 years declines and diminishes from Alzheimer's over the past 2 years, his dignity, the state equality of being worthy of respect, has not diminished. By any most of all, not by me or family members, our 3 children and our 9 grandchildren. Most of all, as his wife of 49 years, as caregiver and power of attorney, I oppose this horrific bill, which is not compassionate at all. Thank you.
Madam Chair, I'm Tom Epps, the co-chair of the Virginia for the American Academy of Medical Ethics. I've been a family physician from Lynchburg, Virginia. I represent the position of the American Medical Association and the World Medical Associations, whose code of ethics about physician-assisted suicide is very clear. Both refuse to use the term MAID, as they state that the act of a physician given an overdose cocktail with the intent to aid a patient's intentional own death by suicide is in fact suicide. And I only use the term PAS, or physician-assisted suicide. I've been doing this and fighting this battle through the AMA to not change that code of ethics for the last 7 years. There are a couple of things in here about this bill that really bother me a lot. PAs, NPs are described as being able to do this. I find that making the diagnosis of death in 6 months is a challenge, and one, in all my experience, is not very good. I would not want them being able to do this. There's no mandatory provision for treatment of depression. 60% of terminal patients have that as a problem. And it takes time for those medicines to work. The same thing takes time for palliative care to work. The division of capacity is vague. It depends upon the prism of what one sees people. In states where it's legal, they even allow telemedicine to be a part of the evaluation. If PAS is so good, why are the statistics so clouded? A terminal lung cancer patient that dies in an auto accident dies from the auto accident. If they jump off a bridge, it's suicide. However, if PAS is used, the cancer is the diagnosis. And the Board of Medicine is called on in this bill to monitor PAS. However, there's no mandatory description that says, other than a voluntary reporting by the physician, that this is what's going on. That there are other warnings. The right to die becomes an obligation to die. We see this internationally. In Canada, that PAS is now really euthanasia, as almost everybody, even though they used the word MAID, only a half a dozen people used self-administration. The physician was the person that did that, and by definition, that's euthanasia. The patient determination usually drifts into others making that decision. Insurance carriers have a not great record for providing expensive care, offering PAS as an alternative. And that physicians that object to this bill calls for them shall refer, even though I would find that ethically something I could not do. I think that I've spent countless hours counseling and treating suicidal patients. The AMA Code of Ethics says PAS is not compatible with the physician role as healer. This has been a part of our ethics for 2,500 years, and I would beseech you not to begin to rewrite our Code of Ethics.
Thank you.
Brought my own chair.
Welcome. I'm glad you did. Seems it's perfect.
Madam Chairperson, members, and presenting senators. My name is Bill Fertig. I live in Virginia Beach, Virginia. A bit about my pathway through life. I was a police officer for 25 years, had an off-duty motorcycle accident, and then I went back to the 911 center for 5 years, so 30 years in law enforcement all told. During that law enforcement career, I dealt with many, many families dealing with suicidal ideation, attempted suicides by aggressive means, firearms, vehicles, as well as overdoses. And the aftermath in every one of those cases was the devastation that the families felt. in my own personal experience, one of my sisters-in-law, who was a nurse, knew very well what her condition was, had terminal cancer, and I felt honored to be able to drive her to her last few chemotherapy treatments when she was no longer safe to drive. And she taught myself and our whole family what dignity in dying really was. All due respect to the senators who promoted this, I see this as neither dignified nor do I see it as compassionate. In Life 2.0, as my wife and I call it, after my injury, I was 16 years, just retired last year, as director of the Spinal Cord Injury Association, wherein I worked with a variety of cases nationwide, including within Virginia. One particularly disturbing and difficult case we worked with was a fellow in Maine who had a profound injury. 4th of July, having fun, dove into the pool, broke his neck. The impact also affected his eyesight. He lost most of his eyesight. He's now quadriplegic. He's on a ventilator. Heard it said, and other people have heard this said in their lives, I wouldn't want to live like, go fill in the blanks. Well, I was that guy. I was that guy. I had 30 fractures and a head injury. I was in a trauma center for a month, and I don't even remember being there. When I woke up in rehab, I had time to figure out, was I going to live? Was I going to move forward, or was I not? So I made that personal choice. I don't know if anybody else here testifying to you is making that personal choice. I know we've had a lot of write-ins submitted. Also and by the way, I'm very happy to have made that choice, and I've had an amazing life and career since then. Things are getting tough. I've been injured 24 years, not a spring chicken. The stuff the improvement I was getting in the first few years, now it's starting to go the other way. It's going to be a tough time. We're tough people. We're going to deal with what life brings us. We're not going to quit on life for our family. A couple of other things I would touch on in my career with United Spinal. I had the honor of meeting just a great guy, just a guy who gets up every morning, chooses to be happy. I affiliate with him closely because he was also a police officer. He was in Chicago, and he got shot at a young age and was rendered quadriplegic, very high level quadriplegia, complete quadriplegia, and ventilator dependency. Other than that, he's actually pretty healthy. And he got home and he went, I'm a young guy, what am I going to do with myself? He started a business, built it into a life-sustaining business. He's still working the business 30 years later. Okay, you can do amazing things. If you're injured, a lot of people fear these chairs. I don't fear the chair. This chair got me up that hill today to come and see you. Otherwise, without appropriate equipment, I couldn't come see you. Another case that I had was a lady also in Virginia, who was dealing with medical bureaucracy, and she was going to opt to kill herself if she couldn't get through. Fortunately, we were able to help her out. I respectfully request that you vote no on this bill. I find it neither dignified nor compassionate. I find it dangerous to people with disabilities who are going through a period of depression, and I thank you for your attention.
Thank you for coming. There's a question, sir? Excuse me. Senator Durant?
Yeah, sir.
Sir?
Oh, I'm sorry.
That's okay. Just a comment.
Sure.
Just from a personal perspective, my own father lived as a quadriplegic for 20 years as a result of a gunshot, and so know the challenges of what it's like as a family member to see through that. And I'm grateful to hear your testimony of the advocacy and the work that's being done in that space to support people who are going through that, especially when it's a traumatic.
Then you personally know that it's not the end of life. Life can be great. When I started getting myself together and I'm doing advocacy on Capitol Hill, and I thought I'm feeling pretty good about myself, I came down the elevator, had my tux on, ready to go to the event. There's a guy in a power chair with a ventilator on the back. I'm going, okay, maybe I'm not that great.
Thank you, sir.
All right, thank you.
Senator Hashmi, you could be excused and come back, and we can buzz you. I would not want to act on the bill without you being there. I understand you're on a subcommittee and may have to.
But they both on the same subcommittee.
Oh, okay, well, my apologies. Who is next? Again, we're going for, thank you.
Thank you, Madam Chair. I'm Jesse Sutherland, and I serve as Federal Policy Director for Americans United for Life. I'm a resident of Alexandria, former resident of your district in Arlington, and was born in Norfolk. I'm a 34-year-old son of a mom who has lived my whole life with clinical depression. I'm here on behalf of Virginians of goodwill to urge your opposition of Senate Bill 280, which would legalize physician-assisted suicide in the state of Virginia. Every patient in Virginia deserves better. There is no compassion in offering suicide as a response to despair and hopelessness. This is not compassion. SB 280 promotes ableism and ageism. It would particularly harm the elderly, those with disabilities, people of color, and the poor. The legalization of this already puts vulnerable people even more in a vulnerable situation. Assisted suicide is discriminatory. Assisted suicide creates a two-tiered system for measuring the worth of human life and lethally judges patients' quality of life based on their terminal illnesses and disabilities. SB 280 undercuts America's national goal of suicide prevention. Just last year, more than 50,000 Americans committed suicide, more than any prior year on record. Data shows that when assisted suicide is made lawful, the rates of non-assisted suicide spike. Activists promoting assisted suicide, organizations like Compassion and Choices and Death with Dignity, have been clever in their approach. First, they push for laws with quote-unquote safeguards. And then when the state embraces assisted suicide, these activists then lobby against those same safeguards, calling them barriers to access. The real goal of assisted suicide legislation is always suicide on demand, regardless of the age or health condition. Look no further than Oregon and Vermont, where they have now lifted residency requirements, and suicide tourism is now beginning. Canada is another grievous case study. There is nothing safe about suicide. There's no middle ground. There's no compromise we can make. There's no sanitizing this. And choice is a myth. Democrats this session have an opportunity to help and not harm. You have the opportunity before you to support the elderly, to stand for disability rights, to help put an end to discrimination, to fund suicide prevention services, and to reform a very broken healthcare system. Legalizing assisted suicide would undermine all of this. As we've heard before, the World Medical Association, one second, I'm almost done. Thank you very much, Madam Chair. The World Medical Association, the American Medical Association, National Council on Disability, and National Hospice and Palliative Care Organization all oppose assisted suicide. Suicide is not healthcare. Suicide promotion strips vulnerable persons of real choice when it comes to end-of-life care. Do not normalize suicide. Believe in our power to do better. Thank you, and I'm happy to answer any questions.
How many minutes are left? The 15 minutes is up. Can I just ask those who are opposed to Senate Bill 280 to raise their hands? Okay, do you have any concluding remarks? Because I did allow 15 minutes on each side, so.
Yeah, I could.
If you could conclude, you seem to be one of the organizers here.
Yeah,
Okay.
Virginia Catholic Conference, but Alliance Against Suicide.
I just want to be fair.
Sure. So thank you so much for your time. So my name is Dan Markley, and I'm a board-certified internal medicine doctor and infectious disease doctor. And I'm here to testify that medical aid in dying, or any other euphemism used to describe physician-assisted suicide, is fundamentally antithetical to everything we stand for as a medical community. And as a physician, I swore to uphold a number of professional and ethical standards, not the least of which was primum non nocere, which means first do no harm. And this foundational principle unites all healthcare professionals and has existed in our medical tradition dating at least back to Hippocrates in 400 BC. As healthcare professionals, we're called upon to heal, but sometimes we can't heal. And when we can't heal, we have to give compassion. And compassion means to suffer with. So as a physician over the years, I've been at the bedside with lots of dying patients who've lost all hope and will to live. And in my experience, in these moments of despair and pain, what these patients need more than ever is love, human contact, and affirmation that despite their suffering, they are no less valuable as a human person than any other person. And when a patient gets to the point where they're asking for assisted suicide, I think it's a sign that our healthcare system and our communities, and sometimes even our families, have failed them. We failed in our compassion. We failed to suffer with. We failed to provide optimal palliative care. And we failed to simply be present for them sometimes in their hour of need. So I think the answer to this crisis is not to affirm the sense of abandonment and meaninglessness experienced by our patients by abdicating our sacred duty as physicians and exchanging our role as healers for that of an executioner. This is definitely a distortion of mercy and should never be considered good medicine. In closing, I think to pass this bill it represents the abject erosion of medical ethics in the Commonwealth, and it puts us at odds with the American Medical Association, who clearly state that physician-assisted suicide is fundamentally incompatible with the physician's role as healers. So I urge all our representatives on both sides of the aisle to unite in a commitment not to abandon our brothers and sisters in their time of need and to seek ethically sound solutions to alleviate suffering. Thank you for your time.
Thank you. I'm going to conclude public comment at this point. I think we have heard the issues that are wrapped around Senate Bill 280. I thank the presenters. Every single person who presented did so clearly, sincerely, and made very valid points. So thank you to everybody who took the time to come. Thank you to those who didn't get a chance to speak but are standing on one side of this decision or on the other. The discussion is now with the committee, and our patron is here if there are questions.
Madam Chair, if I could just introduce a quick technical amendment.
Yes, please.
Thank you.
There's a second. All those in favor signify by saying aye. Aye. Would you? Yes.
A technical amendment, so just to clarify, moving a technical amendment?
Correct. That's correct. So, but please now describe the amendment. The amended bill's before us, but we'd like to hear the technical amendment.
Thank you. Council pointed out that we have defined terminal disease in the legislation, but then the legislation also uses the phrase terminal condition, and so the amendment would conform all throughout the bill, the phrase terminal disease as defined on line 90. Rather than
terminal condition.
Exactly, yes. Thank you.
Okay, and there are a fair amount of guardrails in your bill, as I see it. The written request for medical aid in dying form. You also have a process outlined. Is this a model from another state? Is this something that...
Madam Chair, yes, this is a model that has been used in most of the states that have moved this legislation, and it is the model that Compassion and Choices has been advocating for in many states.
if I might just respond briefly to some of the comments that were made. I just want to stress the point that this is a legislation that addresses the issue of terminal disease, and that there is a limited lifespan that is outlined in the legislation. So disability is not a terminal illness. Depression is not a terminal illness. And so individuals who are not given a limited lifespan by their medical providers would not be eligible. And then secondly, this is purely an option. This is not a requirement for anybody that's involved, including the medical providers. If any medical provider or any hospital sees this as a violation of their institutional ethics, their personal ethics, they will not be participating. It is purely an option for any medical provider that wants to be a part of the team helping the patient make this decision.
I think that's really important.
Madam Chair.
Disability is not a terminal disease is a very important distinction. Yes.
Madam Chair, if I might, I have two questions for the Senator. Madam Chair, I wanted Senator Hashmi to clarify for me whether or not this language allows at any time anyone to submit this request on behalf of the individual directly.
Thank you, Madam Chair, and Senator Aird. The patient themselves would have to make the request. They would make two separate oral requests for the medication with a 15-day waiting period in between, and the patient themselves would have to do a written request with a witness, and the patient would have to self-administer the medication.
Thank you, Madam Chair. My second question, Senator Hashmi, is just to clarify the language around the written request. It asks them to affirm that they are of sound mind. With a team of individuals throughout this process, can anyone contest whether or not that individual is in fact of sound mind?
Thank you, Madam Chair and Senator Aird. The physicians, the medical team would also have to confirm that the patient is mentally of sound mind.
Thank you.
And I would expect that there would be some regulations that would be issued as a result of this bill. Is that correct? The Board of Medicine, I would expect. So there would be even more input in terms of the process and how it's supposed to work. Are there any other comments, colleagues? Well, this has been a very emotional presentation. I respect the opinions of those who presented and those who have chosen to come out to hear the discussion of this. This is an option. This would not be mandated. This would be something that an individual and her family or his family with their physician team in a situation where somebody was seriously terminal within 6 months of dying could contemplate this decision if in fact all of the steps were taken and the person would have to be of sound mind. I know that there are individuals who very much want to take control of how they die. That has been a comment in many of my emails. It certainly has come home to me with our colleague, Congresswoman Wexton. So for those who really strongly disagree with this bill, I understand. I completely get your view, and you don't have to participate in any way, shape, or form. If this bill were to pass, again, it would be voluntary. But I, for one, think it's time that we move the bill forward. That's my personal belief, and I think that it is something that, again, many Virginians may find helpful, Some will choose not to use this. It's entirely their choice. Do you have any concluding remarks?
I don't, Madam Chair, and thank you to the committee for taking the time and listening to the voices on both sides of this very sensitive issue.
Okay, I will entertain a motion, if it's the will of the committee. And this does have to go to finance, as I understand it. There's a fiscal.
Well, it will come to the full
impact.
committee first.
Yes, it will, but just wanted to let you know. So the motion would be, we recommend that the full committee report this. We recommend that the bill be reported and re-referred to finance.
With the substitute.
With the amended, yeah, okay.
So moved.
Okay, motion was made that the amended Senate Bill 280 be reported to the full committee and that it, at that point, be re-referred to finance. Is there a second? I will second that. Okay, we have a couple of proxies here. Will the clerk take the roll?
Senator Durant? Senator Aird?
A. Aye.
Senator Bagby?
Senator Bagby votes aye by proxy.
Senator Suderline?
No.
Senator Favola?
Aye.
Ayes 3, noes 2.
Okay, the bill will go forward to the full committee. Thank you. What do they want to speak to? Okay, I'm happy to do that. What were they?
No, those bills I think are mine and yours.
Oh, yeah, I want to do yours and yours. Now, yours, the two of yours are different.
I have 2 bills.
Madam Chair, I have one more bill.
Yeah.
They're both our bills.
Okay, let's see.
But they're having a challenge outside of the chamber.
Yeah, I think maybe they'll be able to come in. Why don't I have you listed? A second. 2229?
229, yes. Barbara. Mr. Allen, saying thank you.
This was very straightforward. I didn't have a problem with this. Go ahead, Senator Hashmi.
Thank you, Madam Chair and members of the committee. My second bill is Senate Bill.
I'm going to ask you to pause for a moment, and I appreciate all of you who have chosen to come to the meeting. If you are leaving, try to leave quietly. Thank you. We will wait until we move on to our next bill.
That was the whole thing.
So everybody should be able to find a chair, and you're welcome to come up front and be close to the committee members, if that is your wish. If you could shut the door for us, that would be very helpful. Thank you. Thank you. Okay, Senator Hashmi, I asked the committee to focus on Senate Bill 229.
Thank you, Madam Chair, and I hope that this will be a shorter bill for all of us, and I really appreciate the thoughtfulness and engagement of the committee. This bill, too, is a bill similar to what I've been working on for the past 2 years, so this is the third year that I am attempting to introduce legislation that really addresses ways to take care of our military population in particular that is suffering from PTSD, untreatable depression, and issues of...
Could you please close the door? It's very difficult to hear our speaker. Go ahead, Senator Hashmi.
Issues of concern that so many of our military population and veterans suffer from. What has drawn me into this particular legislation is the research that we've seen coming out of Johns Hopkins as well as other research facilities that focus particularly on the use of psilocybin to treat untreatable depression and PTSD. I've talked to many veterans who have come back from the deployments in Iraq and Afghanistan, and they have shared that nothing has worked for them. Nothing has worked in the available medication protocols that are typically available. Nothing worked until they were able to take use of clinical treatments that employ psilocybin, and there's a lot of research that supports this. This particular bill is coming from a group, military veterans, called Reason for Hope, and they have been successfully championing this legislation in other states, and it's called Breakthrough Therapy for our servicemen and women. Just a little bit of background, 15% of U.S. service members who have been deployed to Afghanistan and Iraq are affected by PTSD or depression, and we have about 9% of the population of outpatient health care in the VA is because of depression and depression-related concerns. And following deployments in Iraq and Afghanistan's increases in diagnosed depression cases escalate significantly. As we all know, Virginia is home to a significantly large veteran population, and our ability to provide treatment and care is absolutely essential. And so this bill really seeks to establish an advisory council on breakthrough therapies for veteran suicide prevention. It allows this council to have an opportunity to integrate the research around psilocybin, its efficacies, and to create programs and protocols for treating our population and with these therapeutic options. And so, Madam Chair, this is the bill.
Looks like a good bill, and apparently the council would advise the commissioner on the awarding of grants, so the dollars would actually go to the agency.
Exactly.
And is there a budget amendment to establish the grants?
Madam Chair, we did introduce a budget amendment of $43,000. That was our initial estimate, and now with the FISC that has been returned to us, we would probably need to add another $15,000 to that request.
Okay, very good. It's a very straightforward bill. Do you have anybody who is planning on speaking on this bill?
We may have had somebody online, but I don't know if this room is
This
able
room,
to.
I don't believe, is equipped for online. And in our virtual policy, I said the subcommittees were not going to be taking public comment.
Unfortunately, our folks were not able to travel to Virginia, but I
understand.
I don't believe anybody.
Okay, colleagues, Okay, sir, come right up.
Thanks for this minute. My name is Tom Steffens. I am a former Navy SEAL of 34 wonderful years and a retired Rear Admiral. This bill is terrific. There are so many modalities out there that can help our veterans. There's 700,000 veterans, by the way, roaming around in Virginia, and and about 122,000 active duty. We are in a tsunami of suicides right now. I personally attended 6 celebrations of life for our service members. As tragic as the combat deaths are, but these are even worse. And to see all those particularly in the SEAL community, this storm of suicide has just been awful. So I urge you all to support this bill, and be mindful of what we say about suicide. When we say as a society that assisted suicide is okay, it sends another message to our veterans that seems to be in conflict with what this wonderful bill says. So
we're going to try to address the mental health issues as robustly as we can and as thoroughly as we
appreciate
can.
it. Thanks for the time.
Thank you.
Thank you for your attention.
Let's finish this bill, and then we'll.
Speaking to the bill, Madam Chair.
Okay, I would like a motion.
Yes, Madam Chair, I do have a motion. I want to thank Senator Hashmi for bringing this legislation. As the daughter of a Navy vet and in a district that has the second most veterans in the state, I think as a Commonwealth, if we know that we have a presence of significant veterans and active duty individuals, we have a responsibility to make sure we're providing the necessary resources for them to thrive. And so thank you, Senator Hashmi. I move that we report this legislation.
Okay. Motion has been made that we report the legislation. It will have to be re-referred to Finance, but I'd like a second on the motion. Second? I will second the motion. Okay, will the clerk call the roll, please?
Senator Durant,
Yes.
Senator Aird,
Aye.
Senator
Senator Bagby,
Bagby votes aye by proxy.
Senator Suderline,
Senator Suline votes no by proxy.
Senator Favola.
Aye.
Ayes 4, noes 1.
Thank you. Thank you,
you.
Senator Hashmi.
Thank you, Madam Chair.
Senator Locke. I'm sorry for the wait.
That's okay, my subcommittee went on without me.
Oh, dear. They were not as enlightened if you weren't there.
Okay, I have Senate
Sen-
Bill
24,
and I do believe that there is a line amendment.
Okay. Colleagues,
Actually,
let's
it's one word,
Let's look at Senate Bill 24.
and it's on line 46.
Okay, and it's right before us. After care, you want to insert only?
Yes.
Okay. Okay. I read this, I thought this may be. Amendment has been moved, and I'll second it. All those in favor signify by saying aye. Aye. Okay, the amended bill is before us.
Okay, Madam Chair and members of the subcommittee, Senate Bill 24 makes modifications to the long-term services and support screenings known as LTSS screenings for nursing homes. These screenings are required only by Medicaid. Screening teams in hospitals, nursing facilities, and the community can perform the LTSS screening today, depending on where the individual is located. First, the legislation addresses hospital patients who are on Medicaid. Our laws and regulations today say that a Medicaid patient needs a LTSS screening when they are discharged to a nursing home. DMAS has included in provider manual that LTSS screenings are also require a LTSS screening when Medicaid patients are discharged for short-term rehabilitation stays. This bill will clarify in statute that LTSS screenings are not required for rehabilitation stays in nursing homes. Second, the legislation addresses screening for individuals who still live in their home, for example, personal home or an assisted living facility, and need LTSS screening because they have requested a nursing home placement. Those assessments are currently done by community screening teams, but there are instances when a community assessment team is not able to complete the assessment within 30 days. Under this legislation, the community assessment team may coordinate with the nursing facility screening team to perform the assessment in the required 30-day time frame. The legislation has an emergency clause, so we can get these efficiencies started upon passage. Scott Johnson is here if you have any questions that you would like for him to address on behalf of the Virginia Healthcare Association.
Thank you, Senator Locke. Senator Scott. I almost called you Senator. Scott Johnson. Almost called you Senator.
That's my phone a friend.
Is there anything you want to add to this?
Only thing, Madam Chairman, on behalf of the association, I want to thank Medicaid for working with us on this. We incorporated their technical changes. I want to thank the Virginia Poverty Law Center and the Virginia Ombudsman. Emily and Joni worked with us. They had some concerns, and that's why you've got the one-word amendment. I know of no opposition, and we ask for your support.
It is very straightforward. Senator Locke, is there anybody, did you bring anybody who wanted to speak in favor of the bill? Or, other than Mr. Johnson, is there anybody opposed to the bill? Okay, seeing none. Colleagues, the bill is before us.
Move to report. Second.
Thank you. Okay, motion has been made to recommend reporting to the full committee. It's been seconded. Will the clerk please call the roll? We have the amended version before us. That's what Senator Aird said, so. Go ahead.
Senator Durant,
Yes.
Senator Aird, Senator Bagby,
Aye by proxy.
Senator Suderline,
To report, yes.
Senator Favola.
Yes.
Ayes 5, no 0.
Your bill reports. Thank you, Senator Locke. Okay. Now, Senator Pekarsky, did she have some bills here that she wanted to take by for the day? She's got two bills on the docket, 390 and 392. Yeah, and see if she wants to take both by. I don't see her here. The other, yeah, and the bill she referenced to me is not on our docket today. Okay, Senator Obenshain, I don't see Senator Obenshain here, but I do see Senator Subramanian. I'm going to bring you up. This is Senate Bill 186. Were you able to contact Senator Booker? Yeah, okay. Give us 1 minute.
Take your time.
Okay. Colleagues, I ask you to turn to Senate Bill 186. And I believe you have an amendment in the nature of a substitute.
Move that amendment. Move the substitute.
Thank you, Madam Chair. Just explaining the substitute.
Please, yes.
So the original bill was basically 3 sections, and we're just taking out everything but the middle section, Section 2, and we're turning it into a Section 1 bill. So essentially, we're turning this into a work group of relevant stakeholders that the Secretary convenes to develop a plan for the implementation of a wholesale prescription drug importation program. So, a wholesale prescription drug importation program is exactly what it sounds like, which is, the state, and 8 or 9 other states have done this too. The state would basically be looking at, the cost of prescription drugs here and looking at other countries and seeing if it's feasible and if it makes sense, and so to purchase prescription drugs from other countries and import it back here. The kind of wrinkle with this type of plan is that you have to get approval from the federal government, and so far 8 or 9 states have kind of moved forward with this type of program. One, Florida has gotten that approval, and they're just starting their program. But it's what it comes down to is I talked to a lot of constituents. They're flying to other countries for their procedures. They're flying to other countries to buy their medication. While we try to figure out kind of the costs of prescription drugs here in the U.S., one way to do it is just like every any other product, is to try to see if we can purchase things that are abroad and bring them back here. And so, that's kind of the gist of this bill. Happy to answer any questions. I think the one thing, I was just out in the hallway talking to some stakeholders here, and one thing that I think some folks might want to see is if we also kind of study the feasibility of it as well. And so one thing we might try to think about in this week is whether we put in whether the secretary can look into the feasibility first, and if so, then develop the plan. I think if they find that it's not feasible for Virginia, then there's no point in developing a plan.
Is that right? But that would be. I thought you had moved it, but wait, I didn't take a vote. Okay, fair enough. Senator Durant.
Thank you, Madam Chair. Considering that this is the substitute, we're taking out some core pieces of this one, would it be possible for us to take this by for the week to just have a little bit further discussion on how this is going to?
Sure, I would say I think this may need to go to a couple other committees as well, and so I would just think about whether the timing works.
Actually, it would stay with this committee, and
Okay.
this now is only a Section 1 bill.
Right.
So it seems to be very straightforward. The Secretary of Health and Human Services shall convene a work group. There's somebody before we make a decision on this, I think Chris White has a comment, which I consider you to be a sort of an expert witness.
Good afternoon, Madam Chair.
Good
members
afternoon.
Of the subcommittee. I'm Chris White with the Vector Corporation. I'm here on behalf of Pharma. I do want to thank the patron of the bill for redoing the bill and taking out a lot of the objectionable pieces. As he mentioned, there are 8 or 9 states that have importation programs. Florida is the only one that has gotten FDA approval, but numerous states for numerous years have tried this. And no state has actually made this successful. So I think a work group to determine whether or not this is feasible or not is a very prudent public policy. The issue we'd like to see is if we could add some language to the substitute that determines whether or not this is feasible, and then if so, what would that plan look like? So we'd be happy to work with the patron and try to craft some language that gets to the feasibility piece of this. I think we could probably figure that out in short order. We just got an opportunity. I know this is the second enactment clause of the bill, so we've seen it before. Right. Didn't know that that was exactly what was coming today. So we'd be happy to work with the patron and figure out some feasibility language to put in there. Whether that's before full committee on Thursday or not, I would leave that up to the subcommittee to decide.
Well, I mean, I think we could adopt this substitute, certainly with the expectation that you would be adding feasibility language. And I'm getting a lot of nods here. Okay, so I think there's a motion to
adopt the substitute.
And to recommend to the full committee.
Yes.
Okay, the motion is that we report, let's adopt the substitute first.
Yes.
Take a second, make a second.
I second the substitute.
All those in favor of adopting the substitute signify by saying aye.
Aye.
Okay, so now the discussion is with us, before us on the substitute.
Thank you, Madam Chair.
Senator Suderline.
Madam Chair, I appreciate that. I'd like to ask the senator about the report date, December 1. We just passed an organization plan for the General Assembly last week that would have the pre-filing deadline in November. So I'm generally of the belief that we should not have reports come due December 1st as a result, because if we're going to do legislation on this, what do you think about November 1?
I'm okay with that, Madam Chair.
I think that would be doable because this is just convening a work group. It's not a full-fledged study. So is that?
I'd like to move that then.
Okay.
Amend, strike December, add November.
Add November. Are you amenable?
Yes.
Okay, all those in favor of this amendment signify by saying aye.
Aye.
And then, Madam Chair.
Senator Suderline.
Thank you, Madam Chair. I haven't seen anyone from the administration in here, although there's a lot of people, so I might be missing you. I was just curious if there was anyone from the administration that had any thoughts about doing the work group, given that that's who would be running the show on this. Is there anyone here?
We can,
I can reach out to them as well.
we can reach out. Would you like to take this by for the week and come back? So you can run it by the administration, get language in on the feasibility, and we've already changed your December to November 1st.
Okay.
Is
yeah,
that okay?
As long as you think we have time, Madam Chair, to get
I
through.
do think we have time, because this is simple. Of course,
I'll
we
make that
may get
motion
it.
if you'd like, Madam Chair.
Okay, ask that the substitute go by for the day.
Second.
Okay, all those in favor signify by saying aye.
Aye.
Aye. There you go.
Thank you.
You're 70% there. Okay. Okay, let's see. Senator Pekarsky, I think you were next. Or was Senator Pillia next?
Thank you.
Okay. My apologies if you were here earlier. I had her down. Okay.
Okay. Good afternoon.
Good afternoon.
I will just say that this bill has an amendment in the form of a delayed enactment clause for July 1st, 2025 that has been agreed upon by the
So is this Senate Bill
parties.
392 or
Senate Bill 392,
Okay.
390, we were going to pass by. We're still working on some agreements.
Okay. So first, let me just have a motion to pass 390 by for the week.
So moved.
And there's a second.
Second.
All those in favor signify by saying aye. Aye. 390, we pass by for the week. We're on 392 with the delayed enactment clause. Is that right?
Correct.
Okay. Okay.
Okay. This is SB 392, and right now, throughout most of Virginia, if you were involved in an accident that required emergency care, you'd be able to go to an emergency department or an ED, staffed with a physician. The majority of these emergency departments have an ED physician providing that care. In any emergency, we all want to make sure we are provided the best care possible for ourselves and our loved ones. But in Virginia's current code, it's outdated and allows a physician to be on call instead of on the premises in emergency departments. We want to update this code to reflect current practices as well as match our citizens' expectations that there's a doctor ready and available when they or their family member comes in with an emergency. In a recent study, 97% of Virginians said they wanted to see a physician when they came in with an emergency. This is a relatively simple bill. It clarifies that one physician was primarily responsible for the ER, be on duty and physically present in the ER at all times. And we know that rural Virginians, in particular, have less overall options for health care because they often need to travel longer distances to their nearest ED. They need to have faith that during an emergency, they'll receive the care they deserve. And staffing rural EDs may be more challenging at times than in other localities. So this code change allowed flexibility for any physician, not just emergency department ones, to fulfill the updated requirement, as long as their primary time is spent overseeing that emergency department. I do have a doctor here today that would quickly talk about why it's important to update the code to reflect current standards of practice. And finally, we appreciated the feedback that we received from Virginia Hospital and Healthcare Association. And after talking with them, we agreed to have that delay in enactment put in. So
I think if everybody's
we can
on
support
board, your bill's probably in good shape.
Okay, I like it.
And I think
like that.
I'm happy to take comments if somebody wants to, the organizations want to stand up and just say they agree or they concur. VHHA, I don't see a representative here, but I know the representative from representing the emergency physicians is here. Okay. Amy, did you want to say anything? Amy Seibert?
If Dr. Parker here, he could say just a couple words, but if you really quick.
Okay. Okay.
So hi, thank you, yes. I'm Todd Parker, I'm an emergency physician. I work actually in two rural and critical access hospitals, Eastern Shore and Gloucester. This bill is very important. These days, patients come in, and really simply, we have to take care of everything in those rural ERs. So it is very important that you have a physician and you have the training that a physician's had actually on site in that ER. We don't have time to wait for an on-call physician to arrive. I'm also the medical director of the largest regional transfer center down in Southeast Virginia, and So we handle transferring patients all around the state in between hospitals, and there's a crisis in that. Actually, I was at work before I came up here. In all of our hospitals, we're about 30 to 40% of the beds. There's patients boarding, many of them waiting for transfer to facilities where a bed is not available. ERs have become sort of de facto critical care ICUs these days, where a physician might be managing those patients for hours or days waiting for transfer. So it is important that we have a physician on site able to care for those patients. If it was you or your family member, you would want that.
Yeah, I think quality of care is a factor that we all care about. And we adopted the delayed enactment. So an amended bill is before us, and there's no fiscal impact, so we could.
Move to report.
Okay, motion has been made, recommended to report. Second, I will ask the clerk to call the roll.
Senator Durant,
Yes.
Senator Aird,
Yes.
Senator Bagby,
Senator Bagby by proxy, aye.
Senator Suderline,
Yes.
Senator Favola.
Yes.
Ayes 5, no 0.
Thank you.
Okay,
Have a
your
good
bill
day.
passes.
Thanks.
Thank you. Okay. Senator Pillion, yes, I noticed, I did note you were here before.
Yes,
Okay.
Madam Chair, members of the subcommittee, Senate Bill 620 makes modifications to the long-term services and support, commonly known as LTSS, which are screenings required by Medicaid when an individual, and dealing with those individuals who request enrollment in the program for all-inclusive care, which is commonly known as PACE. First of all, though, I have a substitute, which includes 2 technical amendments recommended from DMAS, and it adds an emergency clause to the bill.
Move the substitute.
Okay, substitutes being distributed. Motion was made to adopt the substitute. Is there a second?
Second.
Okay, all those in favor signify by saying aye. Aye. Okay, substitutes before us.
All right, so you might ask, what is PACE? And I'm happy to tell you that PACE is an all-inclusive program designed to enable people over the age of 55 to age in place. So daily, they are transported to a PACE center near their home for care, and then are transported back home at the end of each day. And there are approximately 1,975 enrollees in the PACE program across the Commonwealth. Today, persons seeking enrollment in PACE are generally screened in the community where they live by a community screening team. Local assessment teams are doing their best, but are understaffed and overworked. Delays in assessment to the enrollment are often more than 70 days. This legislation will enable those screenings to be performed by the PACE assessment teams, which have qualified reviewers already in place. This will enable the assessments to be completed in a timely basis so individuals can get the appropriate level of care that they need rather than waiting 70-plus days. This legislation has incorporated the technical suggestion that Medicaid staff has, and I thank them for that, and I'm not aware of any opposition to the bill. And Scott Johnson, who represents Virginia PACE Association, is here if you have any questions for him.
Okay, Senator Suderline.
Thank you, Madam Chair. I appreciate the Senator's presentation. Can Mr. Johnson just tell us a little more about the physical footprint of PACE across the Commonwealth?
Yes, sir, Mr. Chairman. Scott Johnson on behalf of the Virginia PACE Association. I'll hand the Senator a map, and each of you should have it and drop it off at your office today. There are 13 PACE centers across the state. They're assigned by county and by zip code, and you see the footprint there. And in fact, Madam Chairman, if I may, I have brought Eric Beasley from Roanoke, PACE Center down in Senator Suderline's neck of the woods, and Ms. Ford from Norfolk, who have come here. So if y'all want to step on up and introduce yourself, Madam Chair, if I may, and just have them say their.
Good evening. My name is Miranda Ford. I am the program director for the Centera PACE program. We have 2 centers, one in Norfolk, one in Portsmouth, and we serve participants from Franklin, Surrey, Suffolk, Portsmouth, Virginia Beach, Chesapeake, and Norfolk. And I also stand as the chair for the Virginia PACE Association and Alliance, and I support this bill.
It's a good bill.
My name is Eric Beasley. I travel from Roanoke, Virginia today, where I work as the Senior Regional Director of Business Development for Innovate PACE, which operates PACE program in Roanoke. We have a PACE program in Blue Ridge, Charlottesville, that serves that area. We have a PACE program here in Roanoke, in Richmond, that serves the greater Richmond area and the Tri-Cities area. And we also have a program in Newport News that serves Hampton Roads. And I also serve as the treasurer for the Virginia PACE Alliance, and we would appreciate your support for this bill.
Very good. Your bill really sort of ensures an individual gets a screening quickly.
Promptly.
Promptly.
Rather
So
than wait. And my PACE folks were here last week. They didn't come back today because they felt confident that you would recognize the importance of this bill.
no, it's important that we get services to individuals as quickly as they need it, and I like this. Do you have any other speakers? No? Okay. All right, the substitutes before us.
Madam Chair, I move to report.
Okay.
Second.
and Motion has been made and seconded to report the bill. There's no fiscal impact. All those in favor? Well, I guess I can ask the clerk to call the roll, although I've been
Senator Durant,
making you work.
Yes.
Senator Aird,
Aye.
Senator Bagby,
Senator Bagby's aye by proxy.
Senator Suderline,
Yes.
Senator Favola.
Aye.
Ayes 5, no 0.
Thank you.
Thank you, Senator Pillion. Okay. Are we getting there? Okay, Senator Obenshain. And then I can go to you. You've got to. Do you want? Yes, I will. Okay. Yeah, okay. Now I want you to work it out with Senator Beard, okay?
Okay.
You either merge your bills, figure out a vehicle.
Okay.
Okay, Senator Obenshain, and then we'll just have mine left.
Madam Chair, I've got two bills. Scott, what's ours? What's our bill number? 579. 579 is the easy one first. This 579 deals with the insurance requirements for, no, this is for skilled nursing facilities. And it arises from some very situational issues in which at least one nursing home owner of multiple nursing homes in Virginia is claiming it's insured, yet at the end of cases beating down litigants and claiming that they're going to file bankruptcy and bankrupt settlements, notwithstanding the fact that they claim that they are compliant with our insurance requirements. It is perplexing. Mr. Johnson represents the skilled nursing facilities, and he and I have been in communication about this issue and have resolved that we're going to work together over the next year to figure out what exactly is happening and whether it does call for a legislative resolution or not. So with that, I would ask that the bill be passed over for the year.
Madam Chair,
Senator Suderline?
if you're ready for a motion, I'd like to move that we recommend that the full committee pass by Senator Obenshain's bill till 2025.
Okay. Motion has been made and seconded. Will the clerk call the roll?
Senator Durant, Senator Aird,
Senator Aird is aye by proxy.
Senator Bagby,
Senator Bagby's aye by proxy.
Senator Suderline,
Yes.
Senator Favola.
Aye.
Ayes 5, no 0.
Okay.
Madam Chair, the next bill is Senate Bill 575, and this is a bill that I have worked on with the Harrisonburg City School Board. It is a bill that deals with discharge plans involving students in school division who have been involuntarily committed and released with a discharge plan or have been discharged from services being provided through the Community Services Board. School divisions are not always receiving details of the discharge plan. There are multiple issues created by that. One, and most significant, is the safety issue. And Superintendent Dr. Richards from Harrisonburg City Public Schools has an example that he can provide of a very dangerous, very volatile situation that arose, not theoretical, but arose potentially because the school division was not notified of the potential dangers associated with a student being discharged and released back and re-enrolling in the school without any of that information being shared. Second, we're about maximizing the potential of these students to successfully complete their education. It is critical that the schools be involved in the execution of the discharge planning, and as a matter of fact, it's currently in code that the discharge plan shall include educational and other services that the individual will need upon discharge into the community, yet the discharge plan does not get communicated to the schools, which creates an enormous disconnect and an inability for the schools to assist in meeting those educational needs and providing those educational and other services that are needed.
I have a question.
Yes.
The parents could, of course, bring up the content of the discharge plan in the IEP meeting.
Well, yes, and Dr. Richards maybe is better equipped to answer that than I am, but many of these students may not have an IEP. They may not, it may be in families, and I met with Page County School Board this morning, who just coincidentally told me about a 7th grader who was suicidal, was being bullied. She was involuntarily committed, was released. They didn't receive any information about the discharge plan, and she dropped out of school because they didn't know what the educational services were that were recommended. Subsequent to that, they were able to connect with the mom and dad after she had dropped out of school, after she had been bullied and another crisis had occurred. And the parents, they are poor, they are not well educated, they live in a place called, well, Ahala in rural Page County. And these situations are putting these children at educational and physical risk and others at risk. I know that somebody from the CSBs stopped by my office this morning and raised concerns about HIPAA. And I've consulted and conferred with legislative services, and there are a couple of responses to those concerns. Number one is HIPAA has a clear exception for public safety, for the safety of people who are placed at risk as a result of failure to share that information. And number two, and more importantly, we dealt with this following the Virginia Tech shooting. HIPAA expressly provides for an exemption that permits the disclosure of protected health information as necessary to comply with state law. It is already required in the existing code section that the discharge plan be shared with Department of Social Services and a variety of other agencies who don't deal with these children on a day-to-day basis. Schools deal with them every day and are protected by FERPA too.
Senator Suderline has a question.
Thank you, Madam Chair. I'd ask the senator, if the parents don't want this information released to the school, it's still going to be required to be released under this law, if it were to become law.
That's right, except for the fact that it is required to be released already to local Department of Social Services, the local health department, and other public and private human service agencies. This would involve schools. Senator Favola and I spoke earlier about whether a parental, consent to the disclosure would be agreeable. It's not my bill in terms of, it doesn't affect me specifically. I've conferred with the Harrisonburg School Board, and my understanding is that they would be okay with that if it would increase the level of comfort. We've just got to keep these kids safe and maximize their ability to perform.
I think we do have speakers too, but Senator Suderline.
Madam Chair, if this is acceptable at this time, then I think perhaps we could consider an amendment now. I don't know if council's prepared to draft an amendment similar to what Senator Obenshain just articulated, providing parental consent.
I feel pretty strongly about the parental consent. And these would be youth who are involuntarily committed. Is that correct?
It's my understanding, and I'm placing myself at great risk wading into this area of the law, but it is my understanding that it is for those who are involuntarily committed, but also for students who are discharged from other intensive treatment or from a residential placement.
I mean, certainly the sharing of records has been an issue, and I would rather have a broader policy that talks about this. We don't really have a policy that any of our commissions have delved into in terms of what records should be shared in what format. You hit on something that we have to address. I'm not sure if we have all the answers in this bill. I would like to hear some testimony. But yes, sure, Senator Durant.
So, sir, just to clarify, we were discussing involuntary, but there are situations of a voluntary admission that would this apply to as well?
I'm going to have to let the superintendent answer that question, or council may.
Maybe I would ask council, they drafted it.
Mr. Quagliata, I think, drafted it.
Madam Chair.
Yes.
On line 13, it does read admitted to inpatient treatment.
So, period, if they're admitted to a hospital or voluntarily or involuntarily?
Madam Chair, the provisions of section 16.1-346.1 don't specify involuntarily admitted.
Okay.
So it seems to provide to any inpatient treatment, whether involuntary or voluntary, as well as a minor who is discharged from detention or shelter care pursuant to an order of a juvenile domestic relations district court.
So, Madam Chair, it sounds like it can be applicable for both of those scenarios, whether or not the minor has been involuntary or voluntary.
Yeah.
I
Yeah,
think there's
it's
a gray
broader.
area between they're voluntary but reluctantly voluntary. So I just want to make sure that we're not closing any doors on that one.
So what is disclosed, remember, is not all of the records.
It's
it is a
discharge.
statutorily required discharge plan. That's what is to be disclosed under this, that is to address certain specific items, including the plan shall include mental health, developmental, substance abuse, social, educational, medical, employment, housing, legal, advocacy, transportation, and other services that the individual will need upon discharge. So it's to help try to provide the services that are needed, and this would also address a safety issue.
Well, we have some speakers.
Can I
I'm
have
gonna
my
ask
supporters
that a
first?
chair be brought up. Senator Obenshain, if you could move over a little bit, and we could It's been a little awkward having speakers come up and not have a place to sit, yeah. My apologies, thank you.
Right there. Yes.
Thank you.
And you're the superintendent?
Yes.
of Harrisonburg, okay.
I am.
School system.
Thanks for having me.
Welcome.
Formerly of Loudon County.
That's right.
Right?
What's that?
Blue streaks, right?
Yes, yes, thank you, the Blue Streaks. So thanks for having me.
You're welcome. Do you have a comment on this bill, or?
Yeah, so-
Do you have an example, or?
I can provide examples, sure, without specifics, obviously, want to protect identities. But we're always looking for ways to solve problems, challenges that we face in terms of student safety. And we're always looking for ways to help kids who are facing serious challenges integrate into the schools in a way that is successful for them and a way that is successful for all of those around them. And so this is a problem that we've encountered several times a year. We're a little surprised by a student showing up at our door and enrolling and we hear kind of through informal contacts and conversations, we piece things together, and we know that this student has faced some serious behavioral challenges, but we don't really know the details of that. We like to work with families in terms of knowing what they do at home for behavior, knowing what works and what doesn't work, and so forth. So the same thing with residential treatment. We like to work with facilities to know what has worked, what hasn't worked, how are we most likely to be able to help this student integrate successfully. A couple of examples. One of them, a student came from United States territory, had faced significant abuse in a home there, had come to live with another parent in Harrisonburg. The parent happens to have access to firearms within his profession. The student was found in class after enrolling, and we didn't know anything about this student, to have looked up school shootings on his school-issued device. That was discovered, thank goodness. And that was managed in terms of our policies and so forth, with a suspension, with wraparound services, and so forth. But it was a real struggle to find out anything about the treatments the student had. He went into a residential facility again. We found out it was again. He'd been in several times. And that's kind of a black hole for us. We don't get information from the facility except informally through conversations between our mental health people and their mental health people. Another example, I'll be brief. A student was in a facility recently and developed a weapon out of materials he had found and injured a staff member in the facility and was discharged. According to what we learned, again, it's all informal knowledge and communication, but was discharged for that reason. And then without any information, we, of course, enroll the student into our school. So it would be very good for that student for us to know what treatment plans have worked and what our colleagues, in the facility have worked on, so that we can continue that work with that student.
I appreciate those examples. Thank you.
Sure.
We do have some folks who do want to speak
Okay.
in addition to you, but thank you so much
You're
for
welcome.
coming to share your view. Okay, next speaker.
Good evening, Madam Chair and members of the committee. Jennifer Faison, I'm here representing the Virginia Association of Community Services Boards, and we certainly understand the objective when the goal is to make sure that the children are connected to care following an incident. I think for us, the base policy issue is that simply accessing treatment doesn't necessarily mean that that student is going to be at risk. So by disclosing to the superintendent and the public safety officer, you're kind of alerting them to what might be a routine course of care. And those two members are not part of that individual's treatment team. And so, like I said, I completely understand the goal of connecting to care, but there's also an issue of a chilling effect on accessing care if that student, especially over the objection of the family member, would be subjected to enhanced
How do
scrutiny.
you feel if the family member, if a parent agreed?
I think if the parent agreed, that would go a long way to assuaging, but it's still a disclosure to two individuals in the language in this bill that would not be part of that individual's treatment team at the school.
Right. Yeah, the bill is broader than I would like, but I think there's a point here. So if we don't pass it this year, we have to work on this, and it has to come back in good shape.
I'm
Thank
happy
you.
to answer questions
Thank
if you
you,
have them.
and Ms. Faison. Ms. Miller?
Colleen Miller from the Disability Law Center. With my apologies to Senator Rubenstein, I haven't had a chance to share my concerns with him. As Jennifer Faison said, we think that this bill does kind of work with the assumption that having gotten treatment means you are a risk, and really somebody who has gotten treatment and has been ready for discharge has been declared not to be a risk. So I think that it's really a little bit counterintuitive on that front. As far as sharing the records with the parents' consent, I would say that there's some situations where you would need the young person's consent as well, the student's consent. As you may know, the Commission on Youth looked at some of those issues this year. Might be a good place to consider it. Yeah. Thank you.
Welcome.
Thank you. Good evening, Madam Chair. I'm Kat with Voices for Virginia's Children. We understand and recognize the need for wraparound services for our young people, especially for the safety and well-being of our young people. However, this isn't the way to go about it. Sending these discharge plans to administration and to SROs who are directly connected to law enforcement continues to criminalize mental health for our young people. And this has been brought up many times in our schools in general, and how safety officers and SROs are engaging with our young people who are struggling with their mental health. So just in general, SB 575 will perpetuate more harm, and for that we oppose this bill, and we really hope you consider centering the most important person at the forefront of your mind when choosing this position, which is that discharged young person. Thank you.
I think this bill has hit on an issue that has to be addressed. I'm not comfortable with the way the bill addresses it, but I do think that the Commission on Youth, we did look into a bill that Delegate Les Adams carried, and figured out that we needed to tweak, the Board of Social Services needed to tweak policy so professionals that were participating in the FAPT team had protection in their professional capacity and could therefore disclose information that they weren't sure they could disclose before. And it was a tweak to the social services policies.
Madam
Senator
Chair,
Sutherland.
I would like to move the amendment that I discussed and I think council has prepared.
Yes, Madam Chair, it's prepared in concept. It would be adding language to require parental consent would have to be added in both sections that are being amended.
16.1-34.
Yep, as well as 37.2-505.
Coordination of services.
Now, I don't know exactly what language everybody's amenable to in looking for parental consent, but there is a section of the code 32.1-127.1.03 that deals with the disclosure of health records for minors, and the language used there is pursuant to the written authorization of, in the case of a minor, his custodial parent, guardian, or other person authorized to consent to treatment of minors, or if the minor consented to his own treatment, then the minor himself. So that could be.
I'm in a different place. I want to send this to the Commission on Youth with a letter asking them to study this and come back with recommendations. So I would opt to gently PBI this with a letter, would be where I'm at. but we will act on it.
Well, I hear you, and I appreciate your sincerity. I am deeply disappointed that the community services boards would come and simply voice opposition to providing these kinds of services to the people they're charged with helping without trying to find a solution to this. It's just very, very frustrating, and it's creating serious public safety issues and educational gaps for the people that are being served in this process. So,
You raise a valid point, but I also think the Community Services Board representative had a valid point too. I think we need some stakeholders to think about this, and which is what the Commission on Youth can do. I mean, they have a very comprehensive process. We'll get the judicial system involved. We'll get all the social work people involved. So I move that we PBI the bill gently, but that I write a letter that I recommend to the full committee that it be PBI'd, and that the chair of Ed and Health send a letter to the Commission on Youth to study this situation and come up with recommendations for next year.
Madam Chair, just briefly, I think that hopefully I'll be back on the Commission on Youth again. But I think that we should move forward with the legislation today. This is the subcommittee. It's got a long climb up the mountain before it became law. And I just think that I'm more optimistic that we could put something together. I think my amendment that I offered fundamentally changes the bill, but it continues to get the senator and Harrisonburg schools and all those other folks that are concerned about it where they want to go, which is getting the information. And something that I said, so I think we fundamentally addressed the concerns about, oh, this information's going out without parents' knowledge. It would have the parents' knowledge. And when it was said, well, the schools aren't part of their care team, the schools are, with the wraparound services, are a tremendous part of these children's lives, and they spend more time with these children than anyone else does. And so I think that what we were essentially doing with where the bill would be if amended is we're basically just nudging the parents to say, hey, we'd like you to share this information. So if there's not the votes for that today, that's disappointing to me. But I really think that a really serious issue has been identified. And I think we could make positive progress on this session. So I'm against PBI.
Well, I've got two other proxies. I guess I could use the proxy as a second to my motion.
Well, they're making the motion because you're chairing.
Yeah, they're making, whatever, they're making the motion. Yeah, I guess Senator. No, you did, but I have even broader concerns than I had, and I did go to you, and you were very open to my suggestion about a parental approval, but I just want more work on this, because I in no way want the child to be labeled, and I don't want the child to, not have a productive and helpful pathway forward. And if that...
There is FERPA. I mean, they are bound by educational privacy.
Yes, they are. They are bound by that. But this. Go ahead, Senator Durant.
Sorry, Madam Chair. It just, I mean, we've worked so closely on this space of supporting these children. We know we have a crisis when it comes to mental health, and if there aren't some of those scenarios where parents are engaged in this, with it, and it's a question of between them getting medical intervention and then getting them integrated back in without any connection or conversation. I think that's worth.
Would you be, excuse me?
Yes, Madam Chair.
Would you be willing to take this by for the day and work with some stakeholders and see if you can come up with language that would be acceptable? And if not, then we will do the PBI with a letter to the Commission on Youth.
We talk about what we can do about school shootings, and this is in my view, a tangible thing that we can do to interdict some of the violent behavior in our schools. So I'd be happy to work with the chair.
I think Jennifer Faison, I think Colleen Miller, and I think Voices for Children. I think if you all got together and actually worked on some language, let's bring the bill back next week, okay?
I will
See
make
how
such a
far we get.
motion.
Okay. Motion has been made to pass the bill by for the week, and there's a second, and all those in favor signify by saying aye, and my Senator Lamont and Senator Aird agree.
Senator Bagby.
Oh, Senator Bagby. Senator Lamont, did I say Lamont?
He's all our friend.
He's all our friend, Senator Bagby. Okay.
Thank you, Senator Dave.
You're welcome.
Senator Dave, at least I got the name right.
That's what they used to call me in Carroll County. It was wonderful.
Thank you. All right, now Senator Suderline, you have got Senate Bill 149, which was one that I wanted to take by. You also have Senate Bill 610.
Yeah, they both have the same group of advocates that they're no longer here, so I'd ask you to go by for the day.
Okay.
Oh, well, we got one.
Which one do you, but I don't have Senator Aird
But we
here.
definitely need to take, I'd suggest taking both by now, but we definitely need to take 149 by, since Senator Aird's not here.
Let's have, and that was the one closest to Senator Aird. Okay, so I'd like a motion to pass by Senate Bill 149 for the week and Senate Bill 488.
So moved.
Okay. Second. All those in favor signify by saying aye.
Aye.
Aye. Okay, so Senator Aird and Senator Bagby agree. Okay, so that, I want to be last. Senator Suderline, what do you want to do with 610 now?
I'd take it by for the week.
Okay. Would you make a motion?
Motion to take it back for the week.
Okay, motion has been made, and Senator Suderline seconds, taking by Senate Bill 610 for the week. All those in favor signify by saying aye. Aye, and Senator Bagby and Senator Aird agree. Okay, so we've taken 3 bills by, and the only one left is Senator Favola. Wait, I'm going to speak, so you have to stay for 2 seconds.
Where are we? Oh, your bill?
My bill. And you can't leave, my bill. I have to have somebody here to listen to it.
Oh, this is wonderful. I never thought I'd be chairing during a Democratic majority.
Unless you give me your...
We now have Senator Favola, Senate Bill 179. Let's go.
Okay.
This is great.
All right, so...
Didn't anticipate this morning.
Okay. I have an amendment in the nature of a substitute, which is really a different bill than the one before you. And what...
Council have that for us?
Yeah.
Great. Would someone like to move the...
Move to report?
Move the substitute? All right, we have the motion, and I suspect we have a second. All in favor of adopting the substitute, please say aye.
Aye.
All right, we've adopted the substitute.
Okay, all right. So what my bill now does, and this, by the way, was a recommendation from the Behavioral Health Commission, and also it was from JLARC. And I've got some folks from JLARC here who actually delved into the issue of trying to create a more seamless discharging system from our state mental health facilities. So the substitute creates a pilot, which essentially says that a state facility would be responsible for creating the discharge plan for individuals who were inpatient for 30 days or less. And the pilot will take place in Central State Hospital, Southern Virginia Mental Health Institute, and the Southwestern Virginia Mental Health Institute. And we do expect that a report will be provided. There's enactment language that says the provisions of this act will become effective January 1, 2025, because we needed time, the Department of Behavioral Health needed time to get this set up. But at the end of the day, we really want to learn to see if it makes sense to have our facilities do the discharge planning. I'm not sure if it does. I'm not sure if it creates anything more seamless. We don't know, but we think it's worth trying, and I want to see how it works. And we also have a report to the governor and the General Assembly by August 1, 2025. So we hope the pilot starts in January, and then August 2025, we get a report. So that this essentially is my substitute, and I see that folks are here. I hope you have worked. Jennifer, did you want to speak? Have you worked?
Just briefly, I wanted to thank the senator for the substitute language. This is in keeping with the study that was conducted in 2021 and released in 2022 that didn't have consensus recommendations on all things, but recommended a pilot. So we appreciate it.
Yeah. Thank you for working with DBHDS. Colleen?
Thank you for the solution. The Disability Law Center has been concerned about the number of people who are in the state hospitals and not getting discharged when they're ready to go. So we think this is a great way to kind of figure out where the problem is. We're really grateful that the department is willing to launch a pilot program like this and see whether it helps.
See what we can learn.
Well, thank you. Is there anyone that has any concerns about the substitute as been described that wants to share that? All right, I think it's before us.
I move that I move that our committee recommend reporting the substitute.
All right, we have that motion before us. I don't think there's any discussion. As many as favor the motion to recommend reporting of the substitute to Senate Bill 179 will vote aye.
Aye.
Those
And
opposed?
Senator Aird and Senator Bagby vote aye.
So by a vote of 5-0, the subcommittee recommends report of the substitute Senate Bill 179. And now I'll turn it back over to Senator Favola.
Thank you, Senator Suderline.
That was fun.
That was fun. Okay. Well, that's what we like, fun. I believe that concludes our docket for the day. That's okay. Thank you, team. Thank you. We did well.
To the VCU game.
The what?
VCU plays.